Hello everyone, welcome to a quick revision series on hemodynamics. So already I have given you a very detailed session on the basics or the introduction to hemodynamics, where we have discussed with the Robbins the various causes of edema, hyperemia, congestion, fine. Then Cbc lung, liver. Then we have entered, just brush up some of the points of hemostasis, but I have told you that hemostasis we will cover in detail in bleeding disorders chapters, platelets, hematology. So in this session, I am going to be much more crisp and precise. I am going to just say you the very salient points. These are the must-known points. You should remember this at any cost. Number one, when edema occurs. Edema occurs when there is increased hydrostatic pressure or decreased oncotic pressure. That's it. Just remember 2 points, A, B. Now let us see what are the difference between transudate and exudate. What are the difference between transudate and exudate? First, appearance. Transudate will be clear, colorless. Less than 1.015 is the specific gravity. Protein is less than 3 gram per deciliter. Fine. Cell count less than 1000 per microliter. Permeability, it is normal. Conditions, you will get transudate in case of CHF. It is non-inflammatory. That is why protein poor. It's a protein poor fluid. Whereas, let us come to exudate. It is yellow. Less than 0.15 specific gravity with protein more than 3 gram per deciliter. So it indicates exudate is inflammatory. Cells more than 1000, again inflammatory. WBCs are more. Permeability altered, you will get it in infections and malignancies. Now let us see some of the difference between congestion and hyperemia. Congestion and hyperemia. Congestion is a passive process because of impaired venous outflow. So more deoxygenated blood will get accumulated. There will be edema present, blue-red color. Finally, you will get even hemosiderin deposition. Common in right heart failure, RHF. All these are VVIP tables. Okay? Fine. Hyperemia, again let us see hyperemia. It's an active process due to arteriolar dilation. Edema is absent. Red color, very important. Hyperemia, red color, more blood supply. Am I right? Yes. Seen in inflammation. VVIP this table is. Then we have acute pulmonary congestion and acute hepatic congestion. Remember, they are acute conditions. They are acute pulmonary congestion, acute hepatic congestion. Okay, acute hepatic congestion. In acute pulmonary congestion, there will be engorged alveolar capillaries, alveolar septal edema will be present, focal intra-alveolar hemorrhage. Whereas I have told already that in acute hepatic congestion, there will be centrilobular necrosis with the periportal hepatocytes and a fatty change. Fine. Don't worry much more about these terminologies. We will see in liver path. Now let us see Cbc lung, Cbc liver and Cbc spleen. First coming into Cbc lung. Cbc lung is also called as chronic venous congestion of lungs. Occurs as a result of elevated left atrial pressure, as in case of mitral stenosis in rheumatic heart disease. Gross appearance, you can see the lungs will be dark brown in color. There will be brownish coloration, that is called as brown induration. What is the name of that? Called as brown induration. And on microscopic examination, I told you there will be alveolar septa congested, dilated. There will be intra-alveolar hemorrhages because of the rupture of the capillaries, which are congested capillaries. And the characteristic finding, I have told you, the characteristic finding is the presence of a large number of hemosiderin engulfed alveolar macrophages, we call it as heart failure cells. heart failure cells, they are also called as dust cells. You can see in this picture, you can see in this picture, you can see what heart failure cells. See, this is the hand drawn picture. You can see the septa is thickened. Septa is thickened. And you can see intra-alveolar hemorrhages. Intra-alveolar hemorrhages. Okay, see, this is the thickened alveolar septa. See, again you can see dilated alveoli. And you can see the septa. See, these are the septa which separates the alveoli. This is one alveoli. This is another alveoli. You can see the septa is thickened. Okay, thickened septa. Thickened septa. Okay, thickened septa you can see here. Thickened septa you can see here. Fine. Yes, I'm just drawing here. This is thickened septa. Okay, thickened septa here. And you can see these are alveolar. These are nothing else but what we call it as hemorrhages. Hemorrhages. Okay, fine. Yes. Then what we call it as heart failure cells. That is hemosiderin laden macrophages are present. Okay, fine. Yes. And so that is about CBC lung. Fine. You may get question. What are heart failure cells? That's all. Now let us see what about CBC liver. That is also called as chronic passive congestion. Remember, I told you CBC lung occurs because of left atrial pathology. Whereas CBC liver is mostly, it is a right heart failure. Because of right heart failure, there will be CBC liver. So on gross, as you can see in this picture, okay, you can see the liver is a bit enlarged. Okay, enlarged liver. Okay, enlarged liver. Mottled appearance. Mottled appearance. Okay, and you can see fatty change. Fatty change, that is you can see slight yellowish here, that is fatty change. And you can see some congestion. See, you can see blue color, this is congestion. Okay, fine, congestion. So because of this we have something what we call it as Nutmeg liver. I told you already what is Nutmeg liver. There will be a central area, reddish area surrounded by viable parenchyma, cut surface of nutmeg. It will resemble cut surface of nutmeg. On ME, microscopic examination, you can see centrilobular necrosis with periportal hepatocytes. Fine. And of course fatty change. Let us appreciate these structures here. So those changes here. So as you can see in this picture, you can see this what non-stained white lumens, they are the fat. So that is the fatty change. You can see the central hemorrhagic necrosis. This is the central vein. This is the central vein. You can see hemorrhage around the central vein. That is central hemorrhagic necrosis. Fine. Central hemorrhagic necrosis. Let me appreciate this in this picture. This is the central vein, and what you are seeing now, this is the central hemorrhagic necrosis. Central hemorrhagic necrosis. Fine. Yes. Okay. Then coming into Nutmeg liver. Then coming to the last one, that is what we call the CBC spleen. Yeah, CBC spleen. This is one of a favorite question for INI CET examiners. CBC spleen. This is not usually discussed. So it is also occurs in case of right heart failure, or because of liver cirrhosis it may occur. You can get an enlarged, firm and a tense spleen. Okay, so it will be around 250 gram or more, and spleen has a capsule. The capsule will undergo thickening and fibrosis. So on the cut surface you can see that the liver is also enlarged. Similarly here the spleen is also enlarged and it is heavy. Okay, you can see a grey tan parenchyma. Okay, what is this? Grey tan parenchyma. You can see a grey tan parenchyma. Fine. Yes. So see, this is the hand-drawn picture. Hand-drawn picture. See this huge big thing. Okay, this huge big thing. This is nothing else but the capsule. Okay, you can see that the capsule is thickened. Capsule is thickened. Enlarged spleen. Fine. Enlarged spleen. And what you are seeing this? What you are seeing this? Some nodules with some black. Whenever in hematoxin eosinophil you see something black, that is mostly calcium. So these are called as gamma antibodies or gamma antibodies. This should not be confused with the gummatous lesions. That is gummatous lesions you will see in syphilis. Gummatous lesion you will see in syphilis. These are gamma antibodies. Okay. Yes. So what else in CBC spleen? Let us see the microscopy. You can see that the red pulp will be congested, Okay, and see, there will be hemorrhage, like I have told, like centrilobular hemorrhages. Similarly, or central, in liver I have told you that is central hemorrhagic necrosis. Similarly, there will be hemorrhages here, and this hemorrhage along with fibrosis and iron and calcium pigment, we call it as siderotic nodules or gamma antibodies. So here comes the question. Okay, it has been asked once in AIMS, what are the composition of gamma antibodies? It contains what? Iron plus calcium plus fibrous tissue. Okay, fibrous tissue. So this is the content. They are also called as siderotic nodules. They are also called as siderotic nodules. Okay, they are also called as siderotic nodules. Fine. Okay. So they are called as gamma antibodies. So this is the gamma antibodies. Fine. Yes. Gamma antibodies, and then you can see, gamma, you can pronounce, actually it is, when we write spelling, it is gamna, gamna, but actually normally we pronounce it as gamma, gamma. It's not, don't pronounce it gamma. Gammatus means always syphilis. Don't confuse. Okay, this is a different entity. Okay, gammatus, you will see cases of syphilis. So this is gamma antibodies. It is siderotic nodules made up of iron pigment, calcium deposit along with the fibrous tissue. So you can see the sinuses. Okay, the splenic sinuses will be dilated, congested, increased fibrosis in the red pulp capsule and the trabecula, and gamma antibodies is seen. So you can see the thickened capsule. Okay, you can see the thickened capsule here, and gamma antibodies, which are the siderotic nodules. That is why it appears black in hematoxin USL staining. So what all we have discussed? We have discussed Cbc liver, spleen, lung, then acute pulmonary and hepatic congestion, difference between congestion and hyperemia, transudate and exudate, and why edema occurs. So I hope with this, these are very important points you should remember. Okay, so I hope you have enjoyed the session. Thank you.